Hello, my name is Rebecca Cobb, and I am a family nurse practitioner with SOMC Hospice and Palliative Care. Thank you for joining me today and allowing me the opportunity to discuss SOMC's approach to COVID care in the long-term setting. I want to begin today by discussing why this program was started. A crisis occurred early on when we had COVID positive patients in a local nursing facility where multiple residents were sent from the facility to the SOMC ER within a 12-hour period of time. This obviously stretched the resources of the facility that was sending the patients, the EMS that was transporting the patients, along with the ER, which was receiving all of these patients. The ER was burdened with the difficulty of triaging and determining which patients met admissions criteria, which ones required intensive care, which ones were stable enough to go to a regular medical unit, and which ones were potentially imminent with multiple transfers also occurring into the hospice setting at that time. This obviously allowed our executives to start brainstorming and come up with a plan of how we were going to navigate this issue, because we have multiple facilities in our area, and it would simply be a significant burden on our system if we had 3, 4, or 5 of these facilities sending in large volumes of patients repeatedly due to having symptoms of COVID-19. Within Scioto County alone, we have 10 skilled nursing facilities, which is 829 beds. 682 residents were in those beds at the time of the start of the pandemic. In addition to that, we had multiple facilities in outlying counties that were not Scioto County, including Pike County, and also in Kentucky, in the Vanceburg area, we had some large facilities there as well. We realized as a facility that we would be the sole provider for this geographical area to provide care for all of these facilities that could potentially have COVID positive residents. So just as a statistic, the CDC to date today has reported 726,206 deaths associated with the COVID-19 virus. Of those reported, 137,678 are reported to be out of the long-term care setting. So that just goes to show that this is a very high-risk population and that they do need aggressive attention and aggressive management to kind of negate a lot of that mortality that we're seeing within that population. Our program began because we've had a presence in the nursing homes through our hospice and palliative care program already prior to COVID, and that we had an active program already involved in those facilities that was well established. So we focused on 4 objectives when we began creating this new program. We wanted to assure that residents who need hospitalization are identified quickly and that we are able to get those patients from the facility to the ER to get appropriate care. We also want to ensure that the nurses and physicians who provide services at the facilities are educated and they understand what is needed to manage these COVID patients and what the appropriate treatment options are and which options can we accomplish in the facility versus which options require a hospitalization to accomplish. We had to also assist with education of the patients and families. A lot of the families had difficulty understanding how their loved one could be positive when they typically didn't leave the facility. There was also a lot of anxiety with families based on news and misinformation, along with, that tendency to want to blame somebody for bringing this to a loved one. So we had to do a lot of family education to kind of just to settle down those families who were very heightened. They weren't able to see their family members to begin with, in the facilities. And now not only can they not see their loved one, but now their loved one who doesn't leave has contracted a virus that is dangerous, and they're all very aware of how dangerous it can be. So the stress and anxiety on the loved ones and the family members was extremely high. And we want to make sure ultimately that we were providing care at the appropriate level. So that if a patient could be maintained or managed within the facility, that we were doing that, and that they weren't being sent out unnecessarily, or if the patient became too critical for the facility, we were able to take that decision-making burden off of the facility and say, yes, you know, we're here every day, and we're at that threshold. We've passed the point we need to go. So we help them, you know, with the ease of those transitions, and also to take that burden off of them having to make the decision: is the patient sick enough? Are they not sick enough? When do we send them? You know, should we send them early? Should we send them late? We kind of facilitated that with our daily rounds. So a broad overview of the services that we provided: we educated the family, as I already discussed. We provided early medical intervention, early treatment of symptoms, close monitoring. We also had to provide some resources for ancillary services. Some of the facilities used SOMC for their ancillary services. Some of them were subcontracted out, especially for labs and x-rays. We had some difficulties navigating getting those things accomplished in a COVID unit, because some of those ancillary companies either would or would not provide the services for the COVID patients on a COVID unit. And if they did not, then SOMC would step in and fill that gap, especially in the setting of labs and having blood draws. I know our phlebotomy service really stepped up to kind of come in and help when some of the other companies were not willing to draw those COVID positive patients. We did manage a lot of transitions, either from home to the nursing home when an elderly patient would test positive. If the family could not provide the care, often those patients would be brought into the facility, or from the hospital into the nursing facility if a patient was stable enough that they didn't require hospitalization anymore, but they weren't quite able to go home. A lot of those patients would transition to the long-term care setting so that they could continue their quarantine in a setting where they would still have 24/7 nursing care. We provided very aggressive symptom management so that our patients felt better. And in those unfortunate circumstances where we knew that the patient's prognosis was very poor, we did a lot of end-of-life discussions and establishing goals of care with those families and preparing them when we knew that the chance of a good outcome was very low. We did a lot of collaboration with administrators at the nursing facilities. We provided evidence-based medical interventions. We did a lot of crisis management. When these units initially went up, the facilities were very anxious managing the care of these patients. I think early on, there was so little known about the virus, and there were staff members who were afraid to cover these patients or to provide the care on these units, how to just manage the patient, what the patient's course would look like. And over time, those facilities began to adapt and know what to expect and to be able to identify early signs and symptoms of this patient is going to have a pretty significant change. So those facilities learned how to manage those in a much better fashion over time as they became accustomed to managing sicker patients. And that is another thing that we had to facilitate, is that the nursing facilities had to become comfortable with managing a more acute patient than what they're typically used to managing. But we were able to provide those supports so that that comfort level came over time. And we did also allow for 24/7 access to a provider via call services to all the facilities so that if any patient had an issue, through the night or anytime, we were available to address those needs and kind of coach those facilities through those challenging decisions. So of the facilities served in Scioto County, we were at Best Care, Heritage, Edgewood, Rest Haven, Rosemount, Hillview, Portsmouth Health and Rehab, which is now Pristine, Bridgeport, Piketon Nursing Center, and also Mempford Retirement Center. All utilized SOMC's COVID program to help manage their COVID positive patients. So early on when we started discussing the management of these patients, I mean, we just kind of dove in and started rounding on the patients daily. But it was obvious early on that we needed to do our research to find out, what is the standard of care for these patients? What should we be initiating? What should we be managing? So who did we go to make these decisions, to help build a protocol and to help set up an established standard of care for every COVID patient in every facility? Well, we went to these resources: the CDC, the World Health Organization, Ohio Department of Health, the NIH, UpToDate, Medscape, the Infectious Disease Society of America, Journal of American Medical Association, and so on. But this group of resources was just key in helping us build an evidence-based protocol that we could follow within this facility, so that every patient at every institution had a standard of care. And also, if another provider had to step in because of volume or whatever, then we were able to kind of pass a protocol off to the new provider and say, this is kind of what we're following. This is what we found. This is what the research shows. And these are the interventions that, you can put into place for the patients as you're rounding on them. So some of the recommendations that came out of the literature that was reviewed was, to continue the ACE and ARB therapies, initiate statins if the patient was not already on a statin therapy. We provided appropriate anticoagulation for patients. Now that has to be done with extreme caution because this is a very frail elderly population. So, we had to make individual decisions when it comes to how aggressive we want to be with anticoagulation based on the risk of any type of complication or negative outcome as a result of anticoagulation. So that is definitely one intervention that was individually tailored to each patient as we moved along. Another thing that we had to do is aggressively manage acute dehydration. Some patients may not necessarily have had a heavy symptom burden as far as coughing, shortness of breath, hypoxia, those types of things. But in this population, many of our residents just didn't feel like eating or drinking, something simple that we take for granted. When they're COVID positive, they just don't feel well, they don't want to eat, they don't want to drink. And so they may have had an overall simple course, but if we missed that basic dehydration need, then they would have, sequela that would come out of their course that was not necessary simply because we weren't aggressive with managing their nutrition and hydration status. One of the other interventions was early hypoxia management. So as soon as we identified hypoxia in the setting, we would get the patient initiated on oxygen immediately. We would get them initiated on dexamethasone or Decadron 6 milligrams with a preference of IM if the facility was able to accommodate. If not, we would go with oral, and we would do a 10-day regimen of that as early as possible with the onset of hypoxia. And rarely, we would also combine the appropriate use of antibiotics. It's not highly recommended with COVID patients, but there were some instances throughout the course where it was certainly indicated. And if it was indicated, then we would initiate typically either azithromycin or doxycycline to help manage, any type of sequela that required antibiotics. We did provide early and aggressive symptom management. That was one of the key. We rounded every single day on every single COVID positive patient. So we were able to identify changes on a day-to-day basis with these residents. And I do think that that did help provide better outcomes for them. But symptoms that we managed aggressively: fevers, headaches, body aches, nausea, vomiting, cough, shortness of breath, diarrhea. Those are definitely symptoms that if, the patient was left experiencing those symptoms for extended periods of time, then their outcomes would have declined as a result. Shortness of breath, certainly, and hypoxia, those are two key indicators that we would obviously hone in on. If a patient was becoming profoundly hypoxic and having shortness of breath, we would have to kind of take a pause there and kind of decide, is this someone who's on a decline, or is this a patient that we can turn around with medicines and have a reasonable expectation that they can recover? A lot of these patients are very, very frail. And if you start seeing sort of a profound hypoxia and shortness of breath, their prognosis is very poor. And at that point in time is when we would transition to those more end of life conversations with the family, code status changes, getting them set up, and aggressive symptom management would then transition to aggressive comfort care management of those symptoms, where we would start medications like Roxanol and Ativan in preparation for end of life, if we were going to reach that point. But I do think that the fact that we did manage so many symptoms very aggressive and early on provided better overall courses for the multitude of patients that we did serve. I wanted to take a second to briefly touch on the initial COVID wave versus the more recent Delta wave that we just experienced. I was able to manage patients during both time settings. So the initial wave, we did see a lot more incidences of severe symptom burden in these COVID residents. We did have a much higher mortality in this resident population, and we had a lot more hospitalizations during the initial COVID wave that began in 2020 and ended in January, February of 2021. This recent Delta wave hit our community significantly, but the nursing home setting actually did not seem as drastic as our community setting did, which was very surprising. But there are some things that might have contributed to this, and I think they're important to discuss. The big thing, I believe, is that there were new treatment options available prior to the Delta variant hitting the nursing home population. And so I think that some things did contribute to better outcomes. First off, the vast majority of nursing facility residents have been fully vaccinated. And I would say it's fair to say that the vast majority of the vaccinated patients were either vaccinated with the Pfizer or Moderna two-step vaccine, not the one-step vaccine. But the vast majority of these residents have already been fully vaccinated with a two-step vaccine. Another thing that was not available last year because it was so new to the nursing home population was the infusion of the monoclonal antibodies early on in their course. Now, in the nursing home setting, we have the luxury that once a patient tests positive in the facility begins a scheduled testing system. So oftentimes patients will test positive with no symptoms because they're so early. It's not like the community where the patient is exposed and then, over time they start to develop symptoms, then they start to feel bad, and then they go get tested. These patients, a neighbor was positive, and now they're just getting tested, 2 times a week. And we're finding and identifying these patients prior to symptom onset often. So as soon as a patient tested positive, we were reaching out to either the patient if they were their own decision maker, or the family members, if the patient was unable, and saying, hey, do you want to partake in the monoclonal antibody infusions? And we were able to facilitate this year, which we were not last year, to have the facility house pharmacies provide this medication to the patients in the facility. They did not have to leave, and the nursing staff within the facility did facilitate these infusions. And I would say that I'm very proud of all of these facilities, because where there's a will, there's a way, and they all were able to massively administer monoclonal antibodies to almost every single resident that tested positive with this Delta wave of the virus. I can think of only a handful out of hundreds of patients that were not able or refused to receive the infusion. So what did we find? We found that this wave of infection, although heavily impacted the community, it did still impact the nursing home setting. There was still some mortality. Unfortunately, there were still some hospitalizations, but there was definitely, without a doubt, a significant decrease in overall severity, hospitalization, and death compared to the previous wave of COVID-19 transmission that we experienced last year. So of the outcomes that we found, early intervention resulted in faster recovery, and it also reduced overall COVID symptom burden to the patient. We definitely reduced unnecessary transfers to the emergency department. Truly, I would tell patients, unless somebody needed aggressive ventilation or remdesivir, if a patient would benefit from remdesivir, that is not an infusion that currently the nursing facilities are able to administer. So if a patient requires that, that would require a hospitalization. But other than that, we pretty much attempted to manage everything else in-house at the facilities. We absolutely reduced hospitalizations from the long-term care setting. We decreased mortality. We were also able to increase family preparedness in the setting of a poor outcome. When we knew the outcome, when the patient's course was changing, we were able to begin coaching those families and discussing with them, you know, that we don't expect that the patient is going to survive the infection. And so oftentimes that would give them days to come to terms early on, so that they were able to cope with, you know, with their loss of their loved one. And we did absolutely increase patient and family satisfaction with care, because families were definitely relieved that somebody was checking on their loved one every single day that they were in quarantine, and to know that if there was something wrong, somebody would be letting them know. So the program in action, this is just kind of an overview of what we already discussed. SOMC did receive approval in those facilities mentioned previously to see every single COVID resident upon receipt of a positive test, and we saw those residents daily. We rounded at each facility daily as long as they had a positive in-house. We developed a protocol with the assistance of infectious disease and the pulmonary and ICU physicians to help manage those patients appropriately. Necessary time was spent to educate the nurses in the facility on signs of trouble with these patients and how to manage them, and when we've passed that threshold that we need to send them on. And we definitely increased those nurses' comfort in caring for these patients that were COVID positive. As I said, we discussed them daily: education, and intervention. Those were our keys. We did arrange some telehealth visits when the volume was either low in the facility. You know, if we had 5 or 6 facilities with a lot of residents, and we had another facility that maybe had 1 or 2 that didn't really have a lot of symptoms, we might set up telehealth for that in lieu of an in-person visit, but they were still assessed every day, and any changes, they would get a physical visit with a provider. We provided ongoing communication with the families, and these families weren't able to visit prior to COVID or during COVID. So there was a lot of effort used in trying to involve the families. Many of the facilities did bring in communication devices so that families could see their loved one. I know at some facilities, window visits were arranged where the family could sit outside, the resident was inside. But that ongoing communication with the family to provide that extra level of support when they're already anxious that their loved one, has contracted this virus, and, they know they're frail in this setting. We did primarily maintain all of our residents at the nursing home, and we only utilized hospitalizations in those instances where either their respiratory status required it or they needed remdesivir, which is something, like I said, was not accommodated at the facility. But the vast majority of our nursing home residents were able to quarantine in the facility, be treated in the facility, and recover within the facility. And again, we did provide on-call resources to the facility and the residents 24/7, as long as they had a COVID positive resident on the COVID unit. So in conclusion, our feedback from the facilities was overwhelmingly positive. Our feedback from the families was overwhelmingly positive. The facilities were ultimately empowered to provide a higher level of care for their patients. Most of the facilities do not manage an acute situation like this, and especially not with, 10, 15, 30 residents with an acute illness all at the same time. But these facilities, each one stepped up and were able to really up that standard of care for their patients and provide excellent care within the facility for those residents who were positive for COVID. And as we said, residents were able to be maintained primarily within the facility and avoided unnecessary hospitalizations. And it lessened the burden significantly on SOMC, especially the inpatient setting, not having to receive a high volume of patients from the long-term care setting. So I appreciate you taking the time to listen to this presentation. If you do have any questions, please feel free to reach out to me or my team at any time, and we'll be more than glad to answer any questions or concerns or clarifications that you may have regarding this presentation. Thank you and have a great day.